Our last speaker is Chastre, who's going to discuss non-antibiotic therapies for pneumonia, but really focusing on the potential of other new therapies for MDR pathogens.
So good afternoon, everybody. Thank you, Mike, for the introduction. So this is my disclosure, of course. As you know, as ICU doctors, when we are facing a severe bacterial infection in the ICU, our goal is very simple: killing as soon as possible, as much as possible, the microorganisms responsible for the infection. This is a Terminator strategy, of course. But unfortunately, the bugs have a lot of mechanisms to resist to the action of antibiotics, going from blocking the penetration of the drug inside the bacterium to extruding very rapidly the antibiotics from the inside to the outside of the cell. And it's also possible, of course, for the microorganisms to modify the target of the antimicrobial agent inside the bug or to destroy the antibiotics. For example, using a beta-lactamase for many antibiotics, as you know. Of course, we are responsible, as said by Michael, by the selection pressure we are doing, giving a lot of antibiotics to our patient for the emergence and dissemination of resistance to antibiotics. But remember, we didn't invent the majority of antibiotics. The antibiotics themselves were in fact invented by the microorganisms themselves. And this is probably the most well-known example of that. As you know, Fleming didn't invent penicillin. In fact, thank you. In fact, penicillin was invented by a fungus, which is named now Penicillium, and of course, this is the true inventor of that antibiotics. And most antibiotics we are using were in fact invented by microorganisms. But the microorganisms are not crazy at all. At the same time, they invented the new antibiotics. They also invented the mechanisms for protecting themselves from the new antibiotics. Because of course, the fungus producing penicillin should be able to resist to penicillin, not to be killed by the penicillin, of course. And we have, in fact, very strong data showing that digging very deeply into the permafrost in Alaska, it was possible to recover deep in the ground the microorganisms present more than 30,000 years ago, a long time ago, before any human beings capable of inventing an antibiotic, of course. And interestingly, using metagenomic techniques, it was possible to find inside these very old microorganisms the element responsible for protecting the bugs from vancomycin. The bugs invented vancomycin more than 30,000 years ago, but also the mechanisms protecting themselves from vancomycin. This is a very interesting study, I think. But moreover, even using very effective antibiotics, particularly in patients infected into the lung, it's very difficult to eradicate the bugs from the airways, as you know. This is a very old studies done in the UK, demonstrating that just after introducing the new antibiotics for treating patients with a proven microbiologically documented pneumonia, that okay, it was possible to obtain, using antibiotics, a small reduction in the number of microorganisms into the proximal airways. But after a few days, still there are a large number of bacteria still present into the proximal airway secretions. More than 10 to the 5th colony forming unit by ml. So, okay, it's possible to decrease the bacterial burden into the proximal airways using antibiotics, but only during a small period of time, maybe. And we have also the data showing that. This is a study we did a couple of years ago, comparing 2 durations of therapy in patients with ventilator-associated pneumonia. As you can see, even using a pretty long duration of therapy, 2 weeks of treatment, first of all, the mortality was still pretty important, but also we did observe a lot of relapse, despite, in most of the patients, a regimen combining at least 2 antibiotics efficient against the bugs. So really, we need to be able maybe to modify our strategy. And maybe we need to go from the Terminator strategy to the Gandhi strategy, a non-violent strategy. Using such a strategy, we are now targeting the virulent factors used by the bacteria to target the host, okay? And we have now a lot of new targets for making the bugs completely inoffensive. But we are not anymore killing the bugs, which is a major difference. And there are a lot of potential, of course, advantages doing that. First, we have good data showing that could be effective, efficient, in fact. As you know, Emil von Behring was awarded the first Nobel Prize in medicine a long time ago for his discovery of the diphtheria antitoxin. This is exactly the same strategy, in fact. But there are also some other potential advantages for such a strategy. For example, this will maybe have increased efficacy. We don't know, but it's a possibility. It will also support antibiotic stewardship. And very importantly, it could be able to use this strategy not only for therapy, but also for prophylaxis, prevention of infection, or a preemptive strategy, which could be interesting also. And we have some proof of efficacy of such a strategy, for example, regarding Clostridium difficile infection. As you know, particularly in older patients, it's very difficult to avoid the recurrence of the disease, whatever the antimicrobial agent you will use. But using a monoclonal antibody targeting the toxin produced by the bugs, it's possible to reduce the recurrence rate observed, as shown on the slide. Another possibility for this non-antibiotic approach would be to target the quorum sensing system. As you know, this system is used by many gram-negative bacilli, including Pseudomonas aeruginosa, and this system permits to the bugs to monitor their own population densities and also to activate some virulent genes. In other words, going from harmless type to a very aggressive type. Okay? And this is a major mechanism used by many gram-negative bacilli for targeting human beings. And as you may also know, it's possible to interfere with the quorum sensing system using macrolides. Macrolides have practically no activity against gram-negative bacilli, but some macrolides, such as clarithromycin, could interfere with the quorum sensing system and therefore modulate the density of the population of the bugs. And those Greek investigators did a randomized control study in patients with VAP, and patients were randomized either to a conventional strategy or to a conventional strategy plus clarithromycin for 3 days. And interestingly, in that preliminary randomized control trial, it was possible to document at least a benefit regarding the duration of mechanical ventilation, as shown on the slide. It's also possible now to use monoclonal antibodies specifically designed to target one or several factors of virulence. For example, as shown before, as indicated before, for neutralizing the toxin produced by the bug or targeting the aggregation of the bugs. So many possibilities for interfering with the virulent factors used by the microorganisms. And it's using monoclonal antibodies, for example, it's possible to target the type 3 secretion system, which is a major virulent factor used by gram-negative bacilli and, for example, Pseudomonas aeruginosa. As you know, the type 3 secretion system involves a needle-like complex that penetrates the host cells for injecting inside those cells toxins. And it's possible to use a monoclonal antibody to make the type 3 secretion system ineffective, blocking the needle and the injection by that needle of the toxins. So, and we have now good data in animal models showing the efficacy of such a strategy, blocking the type 3 secretion system, as you can see. And the efficacy of the monoclonal antibody is preserved even when it is injected 4 hours after the onset of infection. So, could be possible to use that type of antibodies in human beings. We did a preliminary randomized control trial a few years ago using such monoclonal antibody for the prevention of ventilator-associated pneumonia caused by Pseudomonas aeruginosa. So, we randomized patients colonized by Pseudomonas aeruginosa, not infected yet, colonized, to document the potential benefit of such a monoclonal antibody. At least it was possible to document a signal in favor of the new monoclonal antibody. Preliminary data, of course. It's also possible to target the LPS, you know. But unfortunately, for the moment at least, it's only possible to target a very specific strain of Pseudomonas aeruginosa, the serotype O11. So a very specific population of microorganisms. So in clinical practice, it will be probably not very efficient because before to inject the antibody, you need to be able to document that the patient is colonized and or infected by serotype O11 Pseudomonas aeruginosa, so which is not so easy. But in a preliminary study, we were also able to show at least some benefit, because compared to the predicted mortality in that observational study, it was possible to have a very high survival rate. Preliminary data once again. Now, it's also possible to build up a monoclonal antibody targeting two virulent factors, targeting the type 3 secretion system, as shown before, but also targeting the exopolysaccharide PSL at the surface of the bug. And as you may know, those exopolysaccharides are used by the bug to adhere, to aggregate to the cells from the host. So we are now targeting two virulent factors in order to treat or to prevent the infection caused by Pseudomonas aeruginosa. And we have also good animal data, as shown on the slide. As you can see, using the new B-specific monoclonal antibody, it was possible to improve the prophylaxis, the prevention of the disease in mice, and it was also possible as a therapy to show the benefit of such a monoclonal antibody. We are now conducting a phase 2 study investigating the potential usefulness of using such a monoclonal antibody, bispecific monoclonal antibody, in patients colonized by Pseudomonas aeruginosa, not infected, for the prevention of pneumonia in mechanically ventilated patients. So we have starting the inclusion into the study, and we will see, of course. It's also possible to use a different monoclonal antibody, and there is also an ongoing study done by Aridis evaluating the potential of such a monoclonal antibody. As I said before, it's possible to design specific monoclonal antibodies for targeting specific bugs. And it's now possible, for example, to target the alpha toxin produced by Staphylococcus aureus. As you know, the alpha toxin is one of the most powerful toxins used by Staphylococcus aureus to kill the cells from the host. So we will see once again, but once again, very good animal data showing the efficacy of this new monoclonal antibody, but also maybe the possibility using this monoclonal antibody to reduce the bacterial burden into the lung in mice infected by Staphylococcus aureus, and also in the kidney. So avoiding the dissemination of the bugs into the body on the mice. This is interesting, of course, because targeting the virulent factors, you are not killing the bug, and you are effective, efficient, whatever the resistance to antibiotics. Using that type of monoclonal antibodies, it's, of course, possible to target methicillin susceptible cocci, but also MRSA. So you are now effective against bugs, whatever the resistance to antibiotics. And there is an ongoing study evaluating the potential utility of such a monoclonal antibody, targeting patient colonized under mechanical ventilation by Staphylococcus aureus. Two other pharmas are doing practically the same type of studies using different antibody. There is one study from Aridis and another ongoing from Arsenis, as you can see. Another possibility would be to use bacteriophages. As you know, bacteriophages are viruses that infect bacteria, in fact. And the beauty of this new weapon is that when a bacteriophage invade a bacterium, it replicates inside the bacterium, kill the bug, and then it's available to infect other microorganisms, and therefore amplifying its mode of action. But there are a lot of potential drawbacks. First, you need to get a lytic phage, and also you need to have the very specific bacteriophage for the bug you are targeting. And it's also possible for the bug to become very rapidly resistant to the bacteriophage. So not so easy to use probably at the bedside, but we will see. We have some very interesting data in mouse model showing the efficacy of bacteriophage for improving the outcome of mice infected by Pseudomonas aeruginosa, for example. So, at the moment, because of the better understanding we have of the factors used by microorganisms to target the host, it could be possible to change our strategy, going from a terminator strategy to maybe a less violent strategy, targeting the virulent factors. And interestingly, it could be the way to go for preventing infection or for treating severe infection. But be careful. This is only the first steps we are making on a very long and difficult road. As you know, there are many possibilities for microorganisms to escape. They are using a lot of different virulent factors to target human beings. So we will see. We will see. Thanks a lot for the attention.
Thank you. That was very stimulating. I know the hour's late, but if we could take a couple of quick questions. Are there any pressing questions from the audience? Jean, let me ask you, I think it's very exciting to talk about the monoclonal antibodies, but the trials, particularly for prevention, seem like they would be prohibitively expensive to develop. And then the use of these products seems very expensive as well.
Yeah.
So is this feasible, or is this just a good idea that maybe will never quite get off the ground?
We will see. It's impossible for the moment to say anything. Of course, before to use such a monoclonal antibodies, because not possible to administer the new monoclonal antibody to everybody in the ICU. So you need to be able to identify the most relevant patient, I would say. So the way to go could be to use the new technologies for identifying patients colonized by a specific virus. And as you know, Mike, it's now possible to do that. For example, using the Cepheid machine or whatever the machine you will use, it's possible to very rapidly identify patients colonized by MRSA, MSSA, Pseudomonas aeruginosa, and so on. So it could be the way to go.
Okay.
But yes.
A hopeful answer. Carlos, for you, do you see the same type of question? Do you see the applicability of aerosolized antibiotic for only refractory pneumonia that's not getting better with anything, or do you see it as routine adjunctive therapy that if the data are positive, should be used for all people with VAP?
Well, what I think is that we need the clinical trials to see first of all if it is effective, and then depends in Latin America, in Argentina, like in Brazil. What we are seeing, where you are seeing now in your ICU, who have seen it 10 years ago. So the problem of the resistance is much worse than in the developed countries, but you are looking at what is going to happen in your countries in the future. So now the problem that they exist in much of the ICUs is that we have by sure 90% of resistance, and if we have this weapon, I don't know how to select in which patients to
Are you
use
using it now routinely or not?
No, we are not using it out because they don't have the trial that is supporting this, no?
Well, I want to thank our speakers. I want to thank you all for being here, and hopefully we will be able to continue future discussions about new ways to deal with this very difficult problem. Thank you again.